बाकी मैंने उसका सारा काम कर दिया।
Sir, it's sharp 7:30. So with your permission, shall we start?
Okay, as you wish.
Thank you so much, sir.
Yeah.
Just give me a minute, sir. A very good evening to all of you present on today's session. I am Nishita from IGCP Group. Welcome all of you on today's session. I would like to request all the participating doctors, please be in this line. Dr. Prashant Prakash sir is already with us. I think there is some network connectivity issue. That's why he has left the meeting. He will be in this meeting very shortly. And today's topic, that is Dr. Prakash is going to share, that is sarcoidosis. And I would like to request all the participating doctors, please be in this session. All the participating doctors, Dr. Prakash is trying to join in this session. I would like to request all of you, please be in this session. Dr. Prakash is already with us. I would like to request all the participating doctors, please be in this session. I would like to request, sir, could you please turn on your camera?
Yes. Yes.
Kindly click on allow.
Yeah.
We are starting today's session. As you can understand that we are Dr. Prashant Prakash is our keynote speaker, and today sir is going to share his precious knowledge on sarcoidosis. And Dr. Prashant Prakash sir is MD in medicine, MD in chest specialist, MAMS. Sir has done also FICP, FIACM. Sir is the professor and head super specialty department of pulmonary medicine at ASYMPTOMATIC Medical College, Agra. And let me share an overview of today's session. Sarcoidosis is a rare and complex inflammatory disease that can affect various organs in the body, characterized by the information of granulomas. It often presents with non-specific symptoms, making diagnosis challenging. The exact cause of sarcoidosis remains unclear, and its course can vary widely from person to person, ranging from self-limiting to chronic and progressive. And today's session, Dr. Prakash is going to share and knowledge to enhance the patient care management, shedding light on the complexities of sarcoidosis in the present medical landscape. Now, without wasting any more time, I would like to hand over the session to Dr. Prakash. Sir, over to you. Please proceed.
Yeah. Thank you very much for this very pleasant introduction. I would just like to beg to differ with my hostess that sarcoidosis is a rare disease, but sarcoidosis is no longer a rare disease, as we will see when I go on with my presentation. ये मूव क्यों नहीं हो रहा? एक इससे करो। वापस पीछे आगे जा रहे हो बस ठीक है। या सॉरी फॉर द डिस्ट्रप्शन। अच्छा, sorry for the disruption. So sarcoidosis is a multi-system disorder, and with characterized by non-caseating granulomatous inflammation at sites of diseases. Most commonly, it affects the lungs and intrathoracic lymph nodes. Sarcoidosis is triggered by exposure to microbial agents in individuals with a genetic susceptibility to disease. Occurs worldwide. It has the highest incidence in Sweden, Denmark, and US, and it's lower in Asians. Females have a slight preponderance. More than 80% occurs between 20 to 50 years, with a second peak arising in females after 50 years. Mortality is 1 to 5%, and in that race plays an important role, with a Black population having a preponderance in mortality. 40 to 80% of mortality from sarcoidosis is from advanced pulmonary disease. Etiology, exact etiology uncertain. We have infective causes, non-infective causes. And one thing we definitely know is there is a smoking negative association. Smoking negative association. So this is a happy news for smokers. There are less chances that they will conquer sarcoidosis. And various gene environment interactions. Again, pathology is the hallmark is basically non-caseating epithelioid cell granuloma. The dominant cell in the central core is epithelioid or modified mononuclear phagocyte. CD4 plus and CD8 plus T cells and B lymphocytes can be seen in the periphery of granulomas, and you have characteristic Schaumann bodies and Hamazaki-Weissenberg bodies in this pathology. So this is a typical pathological picture of sarcoidosis. You have peripheral lymphocyte aggregation. You have non-caseating epithelioid cell granuloma, and you have multinucleated giant cells. Granuloma is also seen in particular areas of the lungs, such as perivascular, peribronchial, and septal regions. Interstitium mononuclear cell infiltrate of predominantly lymphocytes is seen. And the fate of granulomas in sarcoidosis is that they may either resolve or undergo fibrosis, leaving a stellate scar or hyalinized host of a former granuloma. See the varied presentation of sarcoidosis all over the world. One thing which we can very much see is that lungs and lymph nodes are the most common presentation. 95% in US, 76% in Japan, 76% in Europe. Eye variation is a paradox. We have 12% ocular involvement in USA, 8% ocular involvement in Europe, but 50% involvement of eyes in Japan. Skin is almost constant. Skin is 16% in USA, skin is 7% in Japan, and skin is around about 16% again in Europe. So what is the clinical classification of sarcoidosis? First, asymptomatic. Second, acute sarcoidosis with or without erythema nodosum. Third, sarcoidosis with symptoms or signs of pulmonary diseases for less than 2 years. Fourth, chronic pulmonary sarcoidosis for more than 2 years. Dominant extrapulmonary sarcoidosis. And last, fibrocystic sarcoidosis. Asymptomatic sarcoidosis. About 2/3 patients are asymptomatic, luckily. The incidental finding only which you will find is hilar lymphadenopathy. And in some, you will have bilateral pulmonary infiltrates along with this hilar lymphadenopathy. So, second category, acute sarcoidosis. Now, this is basically a very good sarcoidosis. Good in what sense? Characterized by basically acute onset of erythema nodosum associated with bilateral hilar lymphadenopathy, fever, polyarthritis, and often uveitis, which is characterized by the name Lofgren syndrome. Here you are in the legs, lower extremities, you are typically seeing erythema nodosum. Excellent prognosis in this acute sarcoidosis with the remission in 70 to 80% of patients, typically within several months. Now coming to pulmonary sarcoidosis, which accounts for more than 90% of the cases. 40 to 60% will be symptomatic. Non-productive cough is the characteristic feature, and progressive dyspnea on exertion, along with chest pain, wheezing, infrequently hemoptysis, and clinical findings will show 20% showing crepitations in the upper lobe area. For this, chest imaging is very important. Chest imaging is abnormal in more than 90% of known cases and carries prognostic information. Like chest imaging comprises of either mediastinal lymphadenopathy. So in 50 to 85% of patients, you have bilateral hilar lymphadenopathy with what is defined as potato nodes. Big, sharply defined nodes with clear line of translucency, and parenchymal infiltrates being linear or reticulonodular markings in the middle and upper lung fields, right? Apart from patchy focal alveolar consolidations, mimicking infection, etc., etc. So you have a staging of sarcoidosis on chest X-ray also. This underlies the importance of basically how important chest X-ray is. Stage 0 is normal chest X-ray found in 5 to 15%. Stage 1 is only enlarged nodes found in 45 to 65%. Stage 2 is enlarged nodes and parenchymal changes, which you find in 30 to 40%. Stage 3 is parenchymal changes without enlarged nodes of fibrosis, which you find in 10 to 15%. And stage 4 is the end stage disease, fibrosis, which you find in 5%. So this is the characteristic chest X-ray, which you find in sarcoidosis, a varied type of presentation. If you might notice that basically chest X-ray of sarcoidosis, right, very much seems to sometimes resemble tuberculosis also. Hence, you see, there is this term called sarcoid TB, which is sometimes often used in Indian context. Here, chest X-ray shows a GARLAND triad, or what is called as 1, 2, 3 sign. 1, 2, 3 sign being basically 1, you have clearly see the right paratracheal node enlargement. 2, you see the right hilar lymph node enlargement. 3, you see the left hilar lymph node enlargement. CT scan. CT scan shows a mid to upper lung predominance and infiltrates, such infiltrates which are central following bronchovascular bundles. If you see the arrow, which I have just depicted in this picture, you have the infiltrates are moving along the bronchovascular structures. Ground glass infiltrates or honeycombing, multiple discrete enlarged lymph nodes, etc. These are other signs seen on CT scan: galaxy sign, sarcoid cluster sign, reverse halo sign. Now, this is the bad part of sarcoidosis, when you start seeing honeycombing, especially in the upper lobes and along the perilymphovascular areas. Then you have the onset of pulmonary hypertension by, you can see the enlarged pulmonary conus on CT scan. Gallium 67 scan, which is now no more so common, but you still see the lambda sign. The lambda sign meaning to say you have the right paratracheal lymph node, you have the right hilar lymph node, and you have the left hilar lymph node. So lambda sign, which you see in gallium 67 scanning. PFT, usually there many times it's normal. Restrictive disease is what is classically seen, but this is obstruction can also be seen, and DLCO is decreased in less than half of sarcoidosis patients. Pulmonary hypertension, the overall incidence of pulmonary hypertension in sarcoidosis appears to be 5 to 15%. In patients with moderate to severe pulmonary symptoms, the rate of pulmonary hypertension has been reported to be 50% or greater. Now, coming to the extrapulmonary sarcoidosis, which is important. So most common, you have uveitis, and other forms include severe chorioretinitis, optic neuritis, granulomatous conjunctivitis, which is the typical cobblestone-like appearance. Cardiac sarcoidosis, this is a dangerous form of sarcoidosis seen in less than 10%. Happily, there are arrhythmias, heart block, or sudden death, right? Various manifestations such as dilated cardiomyopathy, congestive heart failure, local akinesia, aneurysms. Thallium or technetium system myocardial scanning, cardiac MRI, or cardiac PET are the modalities to diagnose cardiac sarcoidosis. Neurosarcoidosis. This can be as benign as just cranial neuropathies, with unilateral or bilateral seventh nerve being a palsy being the most common form of neurosarcoidosis. Or it can be something insidious such as basilar meningitis or aseptic encephalopathitis, hypothalamic pituitary dysfunction leading to diabetes insipidus, hypogonadism, and hyperprolactinemia. And peripheral neuropathies can form 20% of neurosarcoidosis. Cutaneous sarcoidosis, you have plaques or subcutaneous nodules. Then you have lupus PERNIO. Now, this is disfiguring. Disfiguring face with violaceous plaques and nodules covering the nose, nasal alley, malar areas, and areas around the eyes. And erythema nodosum, you have non-granulomatous paniculitis seen in acute sarcoidosis. Hepatic sarcoidosis, you have active hepatic inflammation with fever and tender hepatomegaly with pruritus. On biopsy, granulomas of all stages of development can be seen in 50%. You have elevated gamma GTT and SGPT, and progression to hepatic cirrhosis is the norm if not treated. Hematological sarcoidosis, most commonly what you have is persistent, bulky, painful, or disfiguring adenopathy, mainly cervical, supraclavicular, axillary, trochlear. You have splenomegaly in less than 10%. You have peripheral blood lymphopenia. You have granulomas in bone marrow. Joint and musculoskeletal, well, we have arthralgias, polyarthritis with erythema nodosum, joint cartilaginous erosion is rather rare, and you have myopathies. Exocrine involvement, salivary and parotid and lacrimal glands. You have enlarged tender glands and or Sitka syndrome with dry mouth and dry eyes. In this, you have this characteristic syndrome, association of fever, parotid enlargement, facial palsy, and uveitis, comprising what is known as the Hereford syndrome. PANDA sign. This is another sign of nuclear medicine in which shows bilateral involvement of parotid and lacrimal glands. Endocrine and renal, you have abnormal calcium metabolism, and basically you have hypercalciuria, which is more frequent than hypercalcemia, and hence kidney stones are a most frequent manifestation of renal sarcoidosis. GI, direct esophageal involvement, gastric sarcoidosis, genitourinary, you have testicular masses and epididymolysis or ovarian or uterine masses. They're pretty rare. Psychosocial manifestations, prevalence of depression was 4% in asymptomatic and 30% in symptomatic patients. So this is also an avenue which has to be covered. Parasarcoidosis syndromes, you have sarcoidosis associated fatigue, small fiber neuropathy, pain syndromes, depression, cognitive impairment, Lofgren syndrome, and vitamin D dysregulation. So, in this gamut of clinical multi-system involvement, how do you diagnose sarcoidosis? Diagnosis is a compatible clinical presentation, the finding of non-necrotizing granulomatous inflammation in one or more tissue samples and exclusion of alternative causes of granulomatous disease. There's some clinical features which are very specific for cardiac sarcoidosis, such as Lofgren syndrome, lupus pernio, Hereford syndrome. In this, diagnosis of sarcoidosis is just very smooth. Others, such as bilateral hilar lymphadenopathy in patients without constitutional symptoms such as fever, night sweats, and weight loss. This is Lofgren syndrome, clinic hilar lymphadenopathy, acute polyarthritis, erythema nodosum. This is lupus pernio. You see it on the nose, ears, cheeks, lips, and forehead. It's pathognomonic of sarcoidosis. And this is the Hereford syndrome discussed, parotid gland enlargement, facial palsy, anterior uveitis, and fever. So, what are the clinical features supportive of diagnosis of a sarcoidosis? History. Lofgren syndrome, very high probability of sarcoidosis. Physical features, lupus pernio, uveitis, optic neuritis, erythema nodosum, very highly probable features of sarcoidosis. Then you have imaging में bilateral hilar adenopathy on chest X-ray, CT, PET, perilymphatic nodules, gladiolinum enhancement on MRI, osteolysis, cysts, sponge out lesions, trabecular pattern of bone, parotid uptake. These are some of the very characteristic features on imaging which will suggest sarcoidosis. And in other testing, you have hypercalcemia or hypercalciuria with abnormal vitamin D metabolism. Typically, sarcoidosis granuloma most often is non-necrotic. Nodular pulmonary sarcoidosis phenotype is mixture of necrotic and non-necrotic granulomas, right? Key pathological features of sarcoidosis, such as granuloma presence, right? You have numerous of them. Granuloma morphology with a typical epithelioid histiocytes and multinucleated giant cells, right? Then the typical fibrosis which starts in granuloma from the periphery with extension centrally into the granulomas, pathognomonic of sarcoidosis, lesion location, which is in perilymphatic areas around bronchovascular bundles and fibrous septa containing pulmonary veins and near visceral pleura. Accompanying histology, you have sparse surrounding lymphocyte infiltrate, negative microorganism, etc. Exclusion of alternative diagnosis is, of course, of paramount importance in sarcoidosis. So you have to rule out TB and atypical mycobacterial infections, fungal infections, hypersensitivity pneumonitis, and chronic beryllium disease. Blood lymphocyte proliferation test is diagnostic for chronic beryllium disease. So these are some of the features. Differential diagnosis are a host of them. We won't be going into the very great detail. Important recommendations have come from both ATS, which is ATS 2020, American Thoracic Society, and BTS, which is British Thoracic Society 2020. Both have come in 2020. Lymph node sampling, is it required or not? High clinical suspicion for sarcoidosis, ATS suggests not sampling of lymph nodes, right? Asymptomatic bilateral hilar lymphadenopathy recommendations for or against obtaining an autologous. So if lymph node sampling is not obtained, close clinical follow-up is very necessary. And if you want to tissue sample, according to ATS guidelines, EBUS guided lymph node sampling is the recommended procedure of choice and not mediastinoscopy. Not mediastinoscopy. Bronchoscopy, endobronchial appearance at bronchoscopy is normal in up to 2/3 of patients with sarcoidosis. Sometimes you will get that nodules, classically 2 to 3 millimeter waxy yellow mucosal lesions. BAL. The BAL is, well, can sometimes really help. An elevated BAL lymphocyte count of 15 to 25% provides support for granulomatous disease, including sarcoidosis. A CD4 to CD8 ratio of more than 4 in the absence of an increased proportion of other inflammatory cell types is highly specific for sarcoidosis, more than 95% when compared with other inflammatory ILDs. This is what the British Thoracic Society clinical statement on pulmonary sarcoidosis says. Yield from biopsy. Endobronchial biopsy gives a yield of 40 to 60%. Transbronchial biopsy gives a yield of 40 to 90%. The diagnostic yield of EBUS TBNA is in my range from 54 to 93% with a pooled sensitivity of 79%. According to ATS 2020, baseline eye examination important in sarcoidosis, baseline serum creatinine testing important in sarcoidosis, baseline serum alkaline phosphatase testing important in sarcoidosis, and as far as serum transaminase testing is concerned, no recommendation for or against has been made in it. In sarcoidosis, patients who do not have symptoms or signs of hypercalcemia, the recommendation for baseline serum calcium testing to screen for abnormal calcium metabolism is a very strong recommendation. And if vitamin D replacement is planned, you should do both 25-hydroxy and 125-hydroxy vitamin D levels before vitamin D replacement. Extracardiac sarcoidosis patients basically suggest performing baseline ECG, routine performing of transthoracic echocardiography or Holter is not really advocated. And cardiac MRI is more specific than both PET or transthoracic echocardiography to obtain both diagnostic and prognostic information. For patients with sarcoidosis in whom pulmonary hypertension is suspected, we suggest initial testing with transthoracic echocardiography. If TTE is suggestive of PH, you go for right heart catheterization. So there are some recommendations which have been made that for new sarcoidosis patients, some examinations are very required, such as calcium should be done annually, creatinine should be done annually, alkaline phosphatase should be done annually, eye examination, cardiac testing, and pulmonary hypertension need not be done annually unless you do not have these manifestations. FDG PET is a helping site. It helps in the site for biopsy in difficult cases. It's an investigation for cardiac sarcoidosis. Serum markers, ACE level, is produced in the epithelioid cell of the sarcoid granuloma. It's inadequately sensitive or specific either to diagnose or exclude the disease. So, treatment indications. There are two indications: potential danger of a fatal outcome or permanent disability, to unacceptable loss of quality of life. What is the consensus approach to the treatment of sarcoidosis? Number one, treatment is not indicated for asymptomatic patients with only intrathoracic lymphadenopathy. Treatment is not indicated in asymptomatic patients with pulmonary infiltrates and mildly abnormal lung function and stable diseases. Oral corticosteroids are the first line of therapy in patients with progressive disease determined by radiology or lung function. Treatment with prednisolone 20 to 40 milligram per day initially for 4 weeks, then reduced to a maintenance dose that will control symptoms and disease progression for 6 to 24 months is advocated. Biphosphonates are recommended to minimize steroid-induced osteoporosis. Inhaled corticosteroids are not of significant benefit. Steroid-sparing immunosuppressive or anti-inflammatory treatments only have an undefined role in sarcoidosis, but should be considered in patients when corticosteroids are not controlling the disease or side effects are intolerable. Of course, the two chief agents is methotrexate, which is a treatment of choice, and an alternative is azathioprine. Lung and heart transplantation should only be considered in end-stage pulmonary and cardiac sarcoidosis. So these are the indications for treatment of sarcoidosis: threatened organ failure, progressive or persistent pulmonary disease, uveitis, unresponsive to topical corticosteroids, persistent hypercalcemia, renal or hepatic dysfunction, palpable splenomegaly or hypersplenism, severe myopathy, disfiguring skin disease, painful lymphadenopathy, and severe fatigue and weight loss. And these are the agents for treatment of treatment of sarcoidosis. You have number one, corticosteroids, number two, second line agents, and number three, third line agents, which are basically investigational agents. Corticosteroids, inexpensive, widely available, rapidly effective, and for severe CNS, cardiac, solid organ involvement, hypercalcemia, it's the first line of treatment. Patients with a high risk for toxic effects of steroids, diabetes, psychiatric disorders, osteoporosis, other agents may be more appropriate for first-line therapy. Cochrane review shows improved symptoms, improved chest radiography, improved biomarkers, improved lung functions over 3 to 24 months of treatment with steroids. Israel HL showed improvement in chest X-rays, symptoms, lung functions, or treatment in steroid growth, especially in stage 2 and 3, but not in 1, and hence in stage 1, some usually does not require treatment with corticosteroids. Higher versus lower dose. This is a big debate. Most treatment guidelines suggest initial dose between 20 and 40 milligram daily, but some trials have showed that even 10 and 20 milligram are also effective. So it is not evident that higher doses of corticosteroids offer additional benefit for pulmonary sarcoidosis. In fact, the phases of corticosteroid therapy in sarcoidosis is typical. You see, you have an initial dosing effect, you have taper to maintenance, you have maintenance dosing, then you have taper off, then you have observation, and then you have relapse. 6 phases of treatment of sarcoidosis with steroids. Response in pulmonary sarcoidosis is typically evident in 3 to 4 weeks' time. After gauging response, the dose is typically tapered to a maintenance level in stepwise increments every 3 to 4 weeks. Most experts consider a taper to 10 milligram or less of prednisone to be successful. The optimal duration of therapy for pulmonary sarcoidosis is unknown, but is typically at least 6 months for sarcoidosis of recent onset. Chances of relapse 14 to 74% for acute disease, 75% for those with chronic. In one observational series, most relapses were observed 2 to 6 months after stopping therapy. When relapses occur, repeat treatment with previously adequate doses is generally adequate to regain control of the inflammatory process. This is a very happy news. Refractory pulmonary sarcoidosis is progressive pulmonary disease despite corticosteroid therapy at adequate dosage defined as at least 10 milligram of prednisolone once a day and duration of at least 3 months after initial dosage of 20 to 40 milligram per day for 1 to 3 months. Need for additional therapy due to lack of efficacy, glucocorticoid toxicity, and severe side effects. This is what comprises the definition of refractory pulmonary sarcoidosis. Alternative agents, we have non-immunosuppressive drugs such as HCQS, tetracycline, pentoxifylline, melatonin, thalidomide, and we have immunosuppressive drugs, methotrexate, azathioprine, mycophenolate mofetil, LEFLUNOMIDE, and anti-TNF factors such as infliximab. Indications for additions of second-line agents is number 1, progression of pulmonary disease or an unacceptable symptom burden despite adequate steroid therapy. Intolerable steroid side effects, inability to taper steroid below 10 to 15 milligram per day, and the presence of major comorbidities that are likely to be affected by steroid therapy, such as severe obesity, diabetes mellitus, osteoporosis, hypertension. So this is the list of immunosuppressive therapies for sarcoidosis. You have prednisolone, you have methotrexate, along with their doses, you have leflunomide, you have azathioprine, you have mycophenolate mofetil, we have infliximab, adalimumab, rituximab, and hydroxychloroquine. You can see this. This is can be seen from any major book and the doses. I'll just delve on some of the important agents. Methotrexate has been shown to be effective in remitting and persistent disease as well as ocular, cutaneous, sinus, and neurological disease. A major potential toxicity of methotrexate and other cytotoxic drugs is bone marrow suppression, which is dose dependent. So you have to do a host of underlying investigations. A lot of patients are not candidates for methotrexate, such as underlying liver disease or chronic infection with hepatitis B or C, creatinine clearance less than 30 ml per minute is also a contraindication. Ingestion of alcoholic beverages should be strongly discouraged in patients with methotrexate, and methotrexate is contraindicated in pregnancy. Dose and duration, you begin with the oral therapy of 5 to 7.5 milligram weekly. Dose is gradually increased by increments of 2.5 milligram every 2 weeks until you attain a dose of 10 to 15 milligram per week. 10 to 20 milligram orally or by transdermal oblique intramuscular injection once a week for refractory nausea, or of those who have not achieved a beneficial effect after 3 to 6 months of oral therapy at 15 per milligram per week has been advocated. Trial of methotrexate therapy should last at least 6 months to allow adequate assessment of effectiveness. Tapering of steroids should be delayed for at least several months after initiating methotrexate. Adverse effects of methotrexate: liver injury, hepatic fibrosis, bone marrow suppression, leukopenia, interstitial pneumonitis, nausea, alopecia, skin rash, teratogenic, toxic reactions to methotrexate. The risk of these side effects can be decreased by supplementation with folic acid of 1 to 2 milligram per day or 5 milligram once or twice weekly. The next important agent after methotrexate in sarcoidosis is azathioprine. Limited data suggests that it is as effective as methotrexate but more toxic. Shown to be effective in pulmonary and extrapulmonary disease. LEFLUNOMIDE has been reported to be effective in treating sarcoidosis either alone or in combination with methotrexate. Compared with methotrexate, the drug has less GI toxicity but a similar rate of liver function test abnormalities. Although pulmonary toxicity with LEFLUNOMIDE is less common than with methotrexate, LEFLUNOMIDE can still cause pulmonary toxicity. LEFLUNOMIDE can also cause peripheral neuropathy. Mycophenolate analogs, they have been reported to be effective as steroid-sparing agents for patients with persistent disease, especially NEUROSARCOIDOSIS. Tumor necrosis factor antagonists. Infliximab, used for various forms of refractory disease, including pulmonary, skin, eye, and neurological disease. Adverse effects of the drug may be considerable, and a high rate of relapse has been reported within a year after the drug is withdrawn. Toxicity, allergic reaction, high risk for reactivation of tuberculosis, contraindicated in advanced CHF. However, infliximab has been used successfully in the treatment of cardiomyopathy secondary to sarcoidosis. So that's a paradox. Adalimumab. So compared to infliximab, adalimumab appears to have a lower response rate and takes longer to demonstrate effectiveness. Golimumab is another agent. Etanercept is a TNF receptor antagonist and has been reported to be effective in some cases of refractory sarcoidosis. So, pulmonary sarcoidosis, high-risk pulmonary sarcoidosis includes those with reduced FVC and DLCO, moderate to severe pulmonary fibrosis or precapillary pulmonary hypertension. Lung involvement per se is not an indication for treatment, but extensive ILD pulmonary fibrosis confers an increased long-term risk of respiratory failure. Treatment should be considered when there is significant reduction in pulmonary function tests, such as DLCO falling less than 65%, spirometric volumes falling less than 70%, or there is a 10% drop from baseline FVC or a 15% drop from baseline TLCO. So these are the indications for pulmonary sarcoidosis. Thank you very much. So thank you very much. I think I can go on, but you see, I think that would be a little too much, and I would like to conclude my talk.
Thank you so much, sir, for the wonderful presentation. You have elaborately discussed all the aspects. So with your due permission, shall we move forward to our question answer round?
Absolutely.
Thank you so much. I would like to request all the participating doctors, if you have any queries or if you want to know anything regarding sarcoidosis from sir, please paste it in the comment section so that I can put it forward to the sir. I have already seen many questions coming. I will take one after another. Meanwhile, you can paste your comments as well. Sir, first question we received: what is the role of glycoprotein KL6 and surfactant protein B within bracket SPD in the pathophysiology of pulmonary sarcoidosis?
In the pathophysiology of pulmonary sarcoidosis, actually, I must beg my ignorance. I'm not very clear about that.
Thank you, sir. Moving forward to our next question, that is, when is lung transplantation indicated in the treatment of sarcoidosis?
Lung transplantation is an absolute end stage condition. As I have already discussed in my lecture, lung transplantation is an absolute final stage when you have an extensive fibrotic honeycombed lung, right, where there is no scope for any kind of improvement. Then only we can go for a lung transplant. And of course, centers for lung transplant are limited. And one thing I would also say is that happily, normally the treatment outcomes for pulmonary sarcoidosis seem to be very good. So fewer cases of pulmonary sarcoidosis really go to that end compared to, say, such as diseases like idiopathic pulmonary fibrosis, etc. So, I mean, they do go. It's not like that they don't do go, but it's a very end stage lung disease.
Thank you so much, sir. Moving towards our next question, you have already covered, that is ATS recommendation, but doctor wants to know what is the ATS recommendation for ECG screening in the patient with sarcoidosis? If you can answer it within 1 or 2 lines.
See, ECG screening can be done. ECG screening can be done, but I don't feel that what are the type of findings which are going to be very specific for sarcoidosis. I don't think so. We are going to find anything very specific for sarcoidosis vis-a-vis transthoracic echocardiography. So I would say that ECG has a very limited role, although it is said that, in this ATS guidelines that ECG screening should be done, and since it's a cheap test, so it can be done. Transthoracic echocardiography would score much better, and of course, as I have already emphasized, cardiac MRI scores better than both transthoracic echocardiography as well as basically PET scan also. Second of all, mind you, one thing we have to take in mind is that the involvement in cardiac sarcoidosis is barely less than 10% of your total population of sarcoidosis.
Thank you so much, sir. We have received many questions, so I have to sort it and give
No problem. No problem.
The next question is, what are the present day complexities in diagnosis pulmonary sarcoidosis?
Present-day complexities in diagnosis of pulmonary sarcoidosis is, one thing as far as India is concerned, is that this disease mimics tuberculosis a lot. So, you see, when you are coming across a patient of, say, suppose stage 1 disease, where you have just hilar lymphadenopathy, where you have, or even if you have hilar lymphadenopathy with pulmonary infiltrates. So there exactly, basically, we have to be very careful in the differential diagnosis of these of this condition. Now, that is regarding number 1, regarding when it comes to tuberculosis. I remember that, when I presented a lecture on sarcoidosis in 2016, in which the initial, at that time, the guidelines were that basically you had to demonstrate involvement of at least 2 organ systems, and you had to demonstrate non-caseating granulomatous inflammation in at least one of them, right? So those were the previous guidelines. This was when I was delivering a lecture on it in 2015 and 16. But now all this has changed. Courtesy, you have 3 guidelines presently right now. You have an ATS guideline of 2020. You have a British Thoracic Society guideline of 2020. And you also have a European Respiratory Society guideline of 2020. So, when I made this lecture, it was more of a compilation of basically all 3 guidelines. And of course, the complexities of sarcoid versus tuberculosis, that is a major problem in India.
Thank you so much, sir. I hope, Dr. Gupta, your queries has been resolved. The next question is, sir, what is the indication for NSAIDs in the management of sarcoidosis?
NSAIDs in the management of sarcoidosis. Look, I have screened BTS, I have screened ATS, I have screened ERS. Apart from amelioration of basically constitutional symptoms, I don't see any particular role for any of these NSAIDs in sarcoidosis. They have not been advocated either in ATS or BTS or European Respiratory Society.
Thank you so much, sir. We are taking last question of today's session. That is, how common is the findings of NCGs in the patient with cardiac sarcoidosis?
How common are the findings of
NCGS?
NCGS, can you elaborate?
Non-casseting granulomas.
How common they are?
How common is the findings of non-casseting granulomas in patient with cardiac sarcoidosis?
That is a difficult question to answer, because you see, non-caseating granulomas in cases of cardiac sarcoidosis is more of a post-mortem finding then, because when the patient has no more, because taking a cardiac biopsy is a very complex procedure, and I don't think so. I have read much in the literature, but see, non-caseating, what it goes by logical extension, and that is that non-caseating granulomas are the hallmark of basically cardiac sarcoidosis, of whether it be of any system, So Why should they logically not be there? Now, when it comes to studies, basically, then you have to demonstrate it. Say, suppose if you have to demonstrate non-caseating granulomas in, say, suppose 100 cases of proven cardiac sarcoidosis who died of sarcoidosis, right? I don't think so that academic postmortems are so common in India.
Thank you so much, sir, answering the questions very well. And you already have elaborated the session very well. So I think there are no more queries. So I would like to also thank our participating doctors for joining today's session, and special thanks to Dr. Prakash for giving us your valuable time. It will definitely help our participating doctors in their clinical practice. Thank you.